Good afternoon. This is Julie Willems-Van Dyke coming to you from the University of Wisconsin Population Health Institute in Madison, Wisconsin. We're very pleased that you have joined us today to our Breaking Down the Rankings series webinar. Today we'll be focusing on improving access to health care. Our webinars are brought to you as the result of the great contribution of numerous partners on our team, including the Robert Wood Johnson Foundation, our team here at the Wisconsin County Health Rankings and Roadmaps program, and then numerous partners across the nation. I'm very pleased today that Judy Solomon, Vice President for Health Policy at the Center on Budget and Policy Priorities, is with us, and in just a moment we'll introduce you to Judy and give you a little bit more background on her expertise in this area. For those of you who may be new to GoToWebinar, I just wanted to spend a moment to introduce you to our technology here. You will see on the left side is your viewer window. That's where you'll be seeing the slides that Judy and I have prepared for you. Over in the upper right-hand corner, you'll see the control panel. And if you see those little arrows on the control panel, those can move the control panel over to the side so it's not interfering with your screen. And then if you click them again, you'll be able to once again see the panel. Because of the number of folks on our webinar today, we will be handling all questions through the question log. So as I present or Judy presents over the next 45 minutes or so, if you have a question, feel free to type it in at any time, and we will reserve a good 15 to 20 minutes at the conclusion of the webinar to respond to your questions. So please feel free to type them in as they occur to you. And again, we will have time at the end of the webinar to address your important inquiries. There's the question log. So here's an outline of what we'll do today. I am going to spend a few moments doing a very brief overview of the County Health Rankings and Roadmaps program, and then I will spend a few moments talking about the data that is collected as part of the County Health Rankings in the access to health care measures. Then I will be turning the webinar over to our colleague, Judy Solomon, who will be digging deeper into how the Affordable Care Act will affect access to health care in our nation. We're so excited that Judy can be with us today on an extremely timely topic at this point in our nation's history. And then finally, as I mentioned, we will complete the webinar with a Q&A period. So many of you have been regular visitors to our County Health Rankings and Roadmaps webinars and have probably seen this logic model before. But for those of you who have not, or this is your first time attending one of our webinars, I just wanted to give you a quick overview of the rankings, why we rank, and what we hope to accomplish. It's all outlined in this logic model here. The County Health Rankings are produced by our staff here at the University of Wisconsin, and we collect population-based data from other sources. There is no primary data collection done here at the University of Wisconsin. So we collect from sources such as the census, the Behavioral Risk Factor Surveillance System. We secure data from the FBI, from the EPA, from state education departments, a wide variety of resources to produce the County Health Rankings. The rankings are released annually, and it is our intent to draw attention to both the rankings and the underlying model that helps describe what really creates health, that health is more than health care, that there are multiple factors that influence how healthy we are in our communities. And through this increased awareness, it is our hope that community leaders will join with others in their community to really hone in, identify what the issues are in your community, set priorities, implement evidence-informed policies and programs so that ultimately will improve the health of communities across the nation. Many of you are probably familiar with this model. This is the County Health Rankings and Roadmaps model. As you will see in the bottom left-hand corner, we believe that if people implement these evidence-based policies and programs, they will be able to affect health factors, or everything that you see in the blue bars on this model. They'll be able to change health behaviors, access to and quality of clinical care, the numerous social and economic factors that influence health, and the physical environment. And by changing those elements, we ultimately will lengthen life and improve quality of life, or ultimately affecting what you see at the top of the model, the green bars on this picture of health. So when we complete the county health rankings, we actually do two sets of rankings, one for those health outcomes that you saw at the top of the model, or as I often refer to it, a picture of today's health in your community, how long you live and how well you live. And then a second set of rankings based on what you see in the blue bars, or the health factors, or that picture of tomorrow's health, the place where you can make changes to improve health. For those of you who are new to the rankings, this is just what I provided you is a really brief overview. I encourage you to go to our website, take a look at the data. Also, if you'd like a more complete and comprehensive description of the rankings, how they're computed, and how you might use them, I encourage you to go to our webinar section on the website and view one of our past recorded County Health Rankings and Roadmaps 101 webinars, where we get into both the rankings and roadmaps in great depth. So, as I showed you in the logic model, the whole point of the county health rankings is to raise awareness about the many factors that influence health so that members of communities can take action to improve health. And because we know health is produced from all of those different elements, we know that it takes more than healthcare providers and public health professionals to improve health in a community. We need our business leaders, our education leaders. We need philanthropy and investors. We need our government leaders, both those who are paid employees of the government and those that are policymakers that decide where laws and money will be distributed in our communities. And of course, most importantly, in the middle of the model, we need our community members to be involved. And so as you listen to Judy speak about the Affordable Care Act and the way it is anticipated to have an effect on your community, I really encourage you to think about who are the partners that you can talk about this important information in your community to help further improve access to care. Many of you are familiar with the County Health Roadmaps, but on our website you will also find a variety of tools and resources to take action. And so again, I encourage you, if you haven't been there, to click on the Roadmaps tab on the home page. You'll come to this page, and you can click on the Action Center, where you'll find tools and resources for each of the steps in the cycle. You can find a document that will help you explore your county health rankings data in further detail. And you can find a wonderful database called What Works for Health that actually will provide you with guidance around where the best evidence is around policies and programs to affect each of those areas in the county health rankings model. So that's a brief overview of rankings and roadmaps, but as I said, today, our webinar today is one of a series that is digging deeper into the different health factors that you see in the model that I showed you previously. And so today we are going to focus on access to care. These are the three specific measures that are in the county health rankings that we use to measure access to care. The first measure is the percentage of people in your community who are uninsured. And this will really be the focus of today's Digging Deeper as Judy guides us through the Affordable Care Act and what effect it will have throughout the nation on reducing this number in communities. The second and third measure of access to care really looks at providers and how many providers you have available in your community. So the first provider measure looks at primary care physicians. This is we calculate a ratio of physicians per population, and the physicians that are included in this measure include any practicing physician under the age of 75 who practices in one of the following specialties: either general medicine, family medicine, pediatrics, or internists. Now, many times people will say, well, what about nurse practitioners or physician assistants? Are they included in this measure? And unfortunately, no, they are not. That is not because we do not think that nurse practitioners and physician assistants are not important in terms of assuring access to primary care. It is simply because the data source that we secured this measure from, the Health Resources and Services Administration, only collects the data on physicians at this point in time. It's possible that could change in the future, but at this point in time, just want to be really clear what this measure measures and what it doesn't measure. And then we do a measure of dentists in the community. This was a new measure added in 2013 to really reflect what we'd heard from people across the nation, that oral health is a very, very important determinant of health, and we had nothing in the county health rankings that really spoke to oral health. So this is a first step in terms of addressing that issue, is looking at what the access to dental care is. And again, this is the number of licensed dentists, not other types of dental workers such as dental hygienists, just dentists. So these are the three measures that we use in the county health rankings to measure access to care. But just as is true in this focus area and is true in all other focus areas, we know there's a lot more to access to care than what we have in the county health rankings. If you will recall, the county health rankings are really meant to be a snapshot in time and an awareness-raising tool. So as you think about access to care in your community and talk with your partners, we know there are many other components of access to care that are really important for you to think about how you can measure either quantitatively or qualitatively on a local level. So it is also important to think about cultural competence of healthcare providers. It's important to think about patients' knowledge and awareness and behavior about how to access the healthcare system. It's important to think about issues such as transportation. Can patients get to a healthcare provider if they need to? Of course, affordability, partially addressed through insurance, but also we know insurance, even people with insurance can face affordability issues. And certainly hours of operation and when people can access care are all also important elements of access to care. So while we're not going to be addressing those elements explicitly today, we do want to raise it that as you think about this important area within the model of what determines health, those are also critical areas to look at. So at this point, I'd like to turn to Judy Solomon, and first we'll introduce her and then turn the microphone over to her for Judy to lead us in breaking down the rankings and talk with us today about improving access to health care and particularly what's happening in regards to the Affordable Care Act. So Judy is Vice President for Health Policy at the Center on Budget and Policy Priorities, where she focuses on Medicaid and the Children's Health Insurance Program and issues related to the implementation of health reform, particularly policies to make coverage available and affordable for low-income people. Judy has testified before state legislatures and spoken extensively to national and state nonprofit groups, and she's often cited by national and state media, including the New York Times, USA Today, the Wall Street Journal, and the Washington Post. And I know she was chatting with me before we went on air today and said she had been doing a number of media interviews yesterday. So we are really privileged to have such an expert and a sought-after voice on these important issues. Judy is a graduate of the University of Connecticut and the Rutgers University School of Law. And so without further ado, I will turn it over to Judy Solomon.
Thanks, Julie, and thanks for inviting me to participate in the webinar today. If you could just go to the first slide here, just to give a sense of where I'm going to go. I'm going to really just start with a couple slides to show the connection, show how research has demonstrated how health insurance affects access to care, because most of what I'm going to be talking about is health coverage. And then I'm going to move to an overview of the new pathways to coverage that are in the Affordable Care Act, look at how we are progressing on the Medicaid expansion and implementation of the new marketplaces. And then finally, shifting gears a bit, we'll go through some of the basics on the new premium tax credits that are designed to help people purchase coverage in those new marketplaces. We're going to take a look at how they're calculated and how they're adjusted for factors like age and like smoking. This is going to be a pretty much of an overview, and I'll tell you where you can get more information on these topics as we go forward. So if you go to the next slide, this slide and the next slide I've really borrowed from the Kaiser Family Foundation website. I'm sure many of you know how valuable that website is in giving you slides and other research, and I borrow from them all the time, as you'll see later in as well. So this slide shows how children and adults fare on 3 measures of access to care, comparing those with employer or other private insurance, those with Medicaid, and those who are uninsured. The results are pretty dramatic, with people with insurance being far more likely to have a usual source of care and far less likely to have postponed or gone without care due to cost. For children, Medicaid and CHIP look almost identical to private and employer insurance on these measures. And they're not that different for adults as well. We often hear here as the center, as we're working with state groups on getting Medicaid expansion in particular, we hear complaints that Medicaid doesn't provide access to care. And shown on this slide, this is really not the case, and there's a lot of other research that reinforces that. There's numerous studies that show that having Medicaid improves access to care, including the landmark Oregon study, which I'm sure many of you are familiar with. Next slide. This slide similarly looks at how health insurance affects access, looking just at adult women, and compares insured and uninsured women on the use of preventive services and cost barriers. Again, you can see that there is a lot more variation. There is a difference. There's a lot more variation on mammography than pap smears, but particularly in the area of cost, you can see that women who are uninsured are significantly more likely to have gone without care due to costs. This slide is not broken down by type of insurance, but just comparing people with coverage and who don't have coverage. So we're going to look now at how the coverage landscape is going to change. When you look at it here, this is what it looks like today in terms of the kinds of subsidized coverage that's available to people with low incomes. I'm sure many of you know that Medicaid eligibility today is based on being in a category as well as meeting income guidelines. This chart shows the median eligibility levels for children, pregnant women, working and non-working parents, and adults without children. We haven't put seniors and people with disabilities who also qualify for Medicaid on this chart because, as you'll see, we're using it to show the impact of the Affordable Care Act. Today, except for a few states, childless adults who are people who don't have dependent children in their care can't get coverage at all. The expansion lifts Medicaid eligibility for all adults up to 133% of the poverty line. Now, some of you may have heard the number 138. The effective limit is actually 138% of the poverty line because there's a disregard of 5% of the poverty line that's factored in. But this is how the expansion changes things. And if you click again, you'll see above the expansion, the design was that anyone who is not eligible for Medicaid with income up to 400% of the poverty line would qualify for subsidized coverage through the premium tax credits we're going to talk about. And above that limit, people who have higher incomes can still purchase unsubsidized coverage on the new marketplaces. However, the Supreme Court changed things in the decision effectively made the Medicaid expansion an option for states. In states that are not expanding coverage, the people with incomes above that red line, those who have income above the poverty line, can still get premium tax credits. But those below are in a coverage gap. They don't qualify for anything. So the next slide really looks at where we would have been in terms of the coverage results in 2017 if all states expanded Medicaid. And even though that's not the case, I think it's still worth looking at what the expectation was. You can see that if all states expanded by 2017, the insurance rate would go down to 10% from 19% where it would have otherwise been without the Affordable Care Act. And Medicaid coverage would go up as a share of how people get their coverage from 13 to 16%. And then the purple is the coverage that people would get through the new marketplaces. So that's how the coverage landscape would change. Unfortunately, though, as the map here shows, only about half the states are expanding in 2014. The reason that we have Wisconsin, and I know Julie's coming to us from Wisconsin, in this funny lines there in stripes, is that the state did not take up the expansion, but it is still providing coverage without a gap. In Wisconsin, people with incomes below the poverty line will qualify for Medicaid adults, and those above will be able to get coverage through the marketplaces with premium credits if they qualify. What the state is foregoing, though, is enhanced federal match that states can get for taking up the expansion. And Michigan is also in stripes, blue stripes here, because it is expanding, but the expansion isn't going to take place, become effective until April. But other than that, what the map shows is the states that are expanding and those that aren't. There's a few states that we're watching closely. We may see them move forward in 2014, including New Hampshire and Virginia, possibly also Pennsylvania. Utah and Tennessee are all having discussions, but the picture here is what we absolutely know for 2014. In the next slide, I thought it would be worthwhile just to take a very brief look at which states are using the federal marketplace and which have their own or a partnership with the federal government. There's a lot of overlap between the federal marketplace states and the non-expansion states, particularly in the South. The choices represented here are having an impact on coverage right now. As a whole, although there are a few exceptions where state websites are experiencing some issues, the state-based marketplaces are doing better in getting people covered. And when we saw the numbers yesterday come out, about close to 70% of those people who had selected plans were actually coming in through the state-based marketplaces. Certainly the hope is that as the federal marketplace improves, that things will look up there and all applicants will be able to easily enroll in coverage. So I wanted to look a little bit more at the coverage gap, and again, I'm relying on Kaiser here. Kaiser Family Foundation recently issued a great report with state-by-state information, so if you're interested, you might want to go to their website and find that. And it gives some numbers on who is likely to be in the coverage gap. I think this slide is the key takeaway from the report. Based on the current state of play, 4.8 million uninsured adults with incomes below the poverty line could fall in the coverage gap. And what this slide shows is that 60% of them live in just 5 states: Texas, Florida, Georgia, North Carolina, and Pennsylvania. And you can see Texas and Florida alone, 38% of people who will fall in that coverage gap of the 4.8 million live in just those 2 states. Now, Florida governor supported expansion, and they got pretty close. You can see what an impact that would have been had they moved forward. So now we are going to shift gears, and I'm going to spend the rest of my time looking at the premium tax credits, who can get them and how they work. We are really just going to skim the surface. For those of you who want to really get into the details of what I'm going to cover and other details on the coverage that is provided under the Affordable Care Act, we have a new project called Beyond the Basics. It has its own website, and at the end of the presentation that will be up on a slide. And we've been doing webinars every 3 or 4 weeks and providing a lot of other materials. So it really is, for those of you who really want to learn more, that's where I would send you. As we saw on the coverage slide, premium tax credits are available to individuals and families with incomes between 100 and 400% of the poverty line. To qualify, you can't be eligible for other minimum essential coverage. This is for people who don't have another pathway to coverage. Minimum essential coverage includes employer coverage in most situations, but there are exceptions if it's not affordable or it's not adequate. It includes Medicaid, it includes the Children's Health Insurance Program and Medicare, as well as TRICARE and some other assorted types of coverage. People must be U.S. citizens or lawfully present in the U.S. However, there's a special rule for people who are lawfully present but don't qualify for Medicaid, usually because of the requirement of a 5-year presence in the U.S. before you can qualify for Medicaid. They actually can receive premium tax credits with income below the poverty line. So this is a tax credit, and income and household size are measured using tax rules. And these rules, modified adjusted gross income, is actually now being used in the Medicaid program as well, except for seniors and people with disabilities, with a few variations. Income is, we call it MAGI, and what it is adjusted gross income, which you probably all know on your tax form, and then you add back foreign income, tax-exempt interest, and Social Security benefits. So it says here the non-taxable Social Security benefits. The end result, it gets a little confusing, but the end result is that Social Security benefits, not SSI, which is the form of benefits for people who qualify based on financial need, but the regular Social Security program, those count as income, even though in large part they're not taxable. And then when you try to figure out where people fit on because this is all done on a percentage of the poverty line basis, you obviously need to know how many people are in the household to figure out where their income puts them. The household size is the tax unit. It's actually pretty simple. Households for Medicaid now are extremely complicated, but they're pretty simple for tax because they use tax rules. So next slide. So this is how the premium credit amount, this is the formula, and we're going to show you some examples in a second. The credit amount that someone gets is equal to the cost of the benchmark plan, and the benchmark plan is the second lowest silver plan, and we'll talk about silver plans in a minute too, available to the person in their exchange minus their expected premium contribution. And the expected premium contribution is determined by taking a percentage that's right in the law that's sensitive to income. It starts at 2% for people with income below 133% of the poverty line, and it gradually goes up to 9.5% at 300 and stays there till 400 times their income. So if you look at the next slide, you'll see John, who is our guy. He's used in all our webinars. And in this example, John has income of $22,980 a year, which is 200% of the poverty line. For someone at 200% of the poverty line, their expected contribution is 6.3% of their income. So what you do is take that percentage times John's income, and you get $1,448, and you subtract that from the cost of the second lowest silver plan covering John. And as you can see here, that's $3,018, and you end up that John has a premium credit of $1,570. That's what John can use to go shopping. John doesn't have to buy that silver plan. He could buy, we'll talk about the tiers in a minute. He could buy Plan A, he could buy Plan C, he could buy a bronze plan, which is cheaper. But whatever he does, he's got that $1,570 in his hand to take shopping. Okay, so here's John again, and if you click a few times, you'll see just another way of looking at John at 24. In the ACA, plans, go back.
Sorry.
Not quite ready yet. In the ACA, plans in the individual market can't charge people more based on their health status or because they're a woman, which they do today. Plans can charge more based on age, but there's a limit. An older person can be charged no more than 3 times what a younger person can be charged. Today in the individual market, the variation can be much larger. So now you can show what happens when John gets older. So here John, and you can click a few times, and you'll see John is 64, and that means his premium credit is 3 times what young John's is. However, and if you click one more time, you'll see this graphically, because their income is the same, their contribution is calculated in the exact same way. So for older John, he's protected against that much higher premium. Now, of course, if he wasn't entitled to a premium credit, he would be paying that greater amount. But the expectation is that most people, will have income that are going to be buying in the marketplaces, will have income in the subsidy range. And you can see as long as you're in that range, the fact that there's age rating is not going to really affect you. You're still going to pay that amount based on your income. So John has a much larger premium credit when he's older. Now, there's another factor that affects how much people pay, and that's smoking. So if we click through a couple times, we'll see the same facts. But now we're going to make John a smoker, and you can click and show his cigarette, and you can see what happens here. Health plans are allowed to charge up to 1.5 times the amount to people who smoke. And in this situation, the premium credit, you're not protected. In this situation, the individual has to pay that surcharge. So you could see here that if John was a smoker, he would have to pay much more. He would have to pay that 0.5 of the premium himself. So that's just a little exercise in showing how the premium credits work. So if you go to the next slide, here we are at the tiers that I've been alluding to, and we call them the precious metals. As you go up to the most precious metal, being platinum, you can see that there's a higher actuarial value. We all have to know these insurance terms now. That means, in general, that the premiums are higher, but the cost sharing is lower. Now, actuarial value is a measure of the generosity of the plan. It's not how much any individual will pay themselves as their share of costs, but it represents how much for a typical population. So it's an actuarial exercise. You take a broad typical population. If all the people in the population were enrolled in the plan, the actuarial value is the overall measure of how much the plan would pay versus how much the members would pay. So in the silver plan, which is the benchmark, the actuarial value is 70%, which means for this typical population, the plan would pay 70% of the covered services. Now, there's a lot of other details here that are important. I'll mention two. One is that there are out-of-pocket caps that protect individuals, and those caps will vary based on income, but for people who don't qualify for any kind of subsidy, they never would have to pay more than about $6,200 in out-of-pocket costs, and it's actually lower for lower income people. The other thing is that people with incomes below 2.5 times the poverty line are entitled to, in addition to premium tax credits, cost-sharing reductions. And what the cost-sharing reductions do is bump up the value of the silver plan. Now, it's not that significant for people between 200 and 250. It only goes up to 73%. But for people between 150 and 200, their plan would have an 87% actuarial value, so close to what a platinum plan would do. So it's going to have much lower cost sharing. And then for people with even lower incomes below 1.5 times the poverty line, they would have a 94% actuarial value. That plan probably doesn't have much, if any, deductible and has, pretty insignificant cost sharing. So that's really important. Now, you can only get those cost sharing reductions if you enroll in the silver plan. They build on the silver plan. Again, there's lots of webinars on our website that go into this in depth. Now, assistance is being provided as a tax credit. Most people have to, well, all people have to pay their premiums every month. So it's not like you can really wait until the end of the year for your premium credit. You have to pay that premium every month. So the premium credits are payable in advance. And people go to the marketplaces to get a subsidy, an advance payment determination. And that's based on what they estimate their income to be for the coverage year. So right now, when people are applying for 2014, they're making an estimate of what they expect their income to be in 2014, and they're getting an advance payment amount, a monthly amount, based on that estimate. People can wait until tax filing and claim it on their return. They would just have to enroll in a marketplace plan and pay the premium themselves. The advance payments are sent directly to the insurer. People don't get them in their hand, and then they pay the balance. Okay, last slide, I think. So the marketplace makes an advance determination. The final amount of the credit is based on actual income as represented on the tax return. And at that time, there's a reconciliation. The advance payments that were made are reconciled with the actual income on the tax return. And depending on how it works out, if somebody's income went up from when they estimated it, they may have to repay. If income has gone down, they may actually get more of a credit as a refund at tax time. There are caps on the amount you have to repay that are pegged to income. And there are lots of things that people can do to try and limit their exposure to repayment, including taking a smaller credit than the marketplace says they're entitled to, and certainly by reporting substantial changes in income that occur during the year to adjust the advance payment they're receiving. So if you just go to the last slide, the URL, the website for our Beyond the Basics project is there along with the center's website. My email if you have questions, Twitter feed if you follow people. And we are doing a webinar next week, next Wednesday. All that information is on the website. So thanks, and I think we have time for questions.
Yeah, we do. Thank you, Judy. That was really, really helpful to help introduce us and answer a lot of questions about what we're hearing in the media right now. So I encourage you at this point in time, if you have questions based on Judy's presentation, feel free to type it into the question box, and we will be going through those in a moment. We also have some questions that were sent in prior to the webinar when you registered, and so we'll start with a couple of those. And actually, I'm going to ask you a question based on what you were just talking about, Judy, because this is something I've heard from a lot of people who have gotten on the exchanges and moved forward. You know, contrary to what we've heard in the media, I've actually talked to a number of people who were surprised by how affordable the products on the marketplace were going to be to them, and actually were planning to spend more money than that. So if you were talking to someone who said, you know, I thought I was going to pay, I'm making up numbers, $200 a month, and it only says $100. I'm worried about my income shifting. Can I pay $200 a month instead of the $100? Are they able to do that? And how would that work out?
Yeah, I mean, I think, you know, and my understanding is the way it's eventually going to work is that there's going to be a slider. You know, everything isn't working as well as it can. You can always take less of an advance payment than they determine you eligible for. That was a kind of complicated way of saying it. So let me just give an example. So if they say, based on your income, based on your estimate, your advance payment is $200 a month, and then whatever plan you pick, you're going to pay the difference. You could say, I think I can swing it. I only want to take $100 a month. You can do that. What you can't do is say, I want $300 a month.
Right.
Now, what taking the lesser amount is if it turned out that 200 was right, then you're going to get a nice amount when you file your taxes. You're going to get the difference as a refund. If it turned out that you were right to be nervous that your income has gone up, you expected that raise and you got it, or you thought you might work more hours, then you'll probably end up even, or maybe a little better off. So it's always and what we say to people that are really near that 400% line in the webinars, we always say you're the people who really should think about whether you can swing it without the credit. See what happens at the end of the year, and if you're eligible, take it at tax time. And the reason is that if your income does end up being over 400% of the poverty line, you're considered not to have been eligible at all, and you have to pay it all back. So you could have substantial liability. But I think for most people that are in, anywhere comfortably within that eligibility range, and they don't see any possibility that they're going to go over 400, they can adjust it. And then the other thing is always to remember that if things change, another change that can happen to people is your household can change. So you may have been determined eligible with that adult child in your household, but then they got a job and left the house, and they're no longer a dependent. That's going to change things for you too. So those things need to be reported.
So would it be fair, Judy, to say this is similar to figuring out how many deductions you would have on your taxes in a year? I know, sometimes people have 2 deductions, 2 exemptions, but they'll put 0 so they're sure that they have more money taken
Yeah.
out of their taxes. Is that a fair, similar comparison that people might
It's
be
like
familiar with?
that. Yeah, it's like that. And if anybody on the call is self-employed or has a self-employed family member, it's also similar to the estimated taxes that you pay
Mm-hmm.
quarterly. Again, there's a balance between what you can afford versus, that you have to pay that monthly insurance premium. And how much risk you're willing to take in a sense. So I think people are going to, some people are just going to need the credit to be able to afford, particularly at people at the lower end of the income range. And for them, what we would say is just really pay attention if your income is going up. But for people, who have higher incomes and they feel like they can swing it, as you said, the premium is lower than they expected. You can wait, and then you'll get a nice little bonus when you file your taxes.
Great. Well, one question that we've had come in is that people are expressing concern that as the percentage of people with health insurance, and particularly the percentage of people who have Medicaid, increase in communities, will we have an adequate supply of healthcare providers to provide all these additional people with health care? I'm sure this is a question you've heard around the nation. What are your thoughts on that, Judy?
So, it's not an area of my expertise, but I do know enough to know that obviously, I think everyone recognizes that provider capacity is an issue. It came up a lot as I was traveling around talking about the Medicaid expansion in states, where there was some reluctance to expand. And I think, what we always have to really think about is that we're talking about people who are, living in the state right now. And so whether they're insured or uninsured, they're going to be getting some kinds of care. And uninsured people do get care. They may not get the right care in the right place at the right time. So I think equating sort of having to wait till we have enough providers to cover them, there's a lack of logic there, and really what we need to do is work on both problems as hard as we can to solve them. There really is no ability to wait. I mean, that's sort of the only way I've been able to kind of resolve it for myself without minimizing the question. We would certainly acknowledge that provider capacity is an issue.
Great. Another question is that even with this expansion and people being able to secure more health insurance, there are still going to be gaps. And so what counsel do you have for communities about what recommendations they can make to people with high deductibles, or what are communities going to do with people who choose to pay the fine instead of secure health insurance?
Well, I mean, certainly for that latter group, I think, they're kind of in the same place now. I think to the extent we're talking about safety net providers and so on, I know they're very engaged in the effort to educate people and get them enrolled, because the more people that we can get enrolled and limit the exposure to uncompensated care, the better job we can do in educating people about what those coverage options are. For example, if you have someone whose income is within that range of being able to get a cost-sharing reduction, they need to really understand that when they take that premium credit, it really is important for them to buy that silver plan, even though it may be a little more expensive than the bronze plan. Because if somebody, say, has income at 140% of the poverty line, something like $14,000 or $15,000 a year for an individual, they're going to get a plan that really doesn't have a deductible if they use their subsidy to buy the silver plan. If they take the cheaper plan, which sometimes they may be able to get without any payment at all, Then they're going to be in a bronze plan that has a 60% actuarial value, and that plan is going to have a very high deductible. So I think, one of the real first things we need to do is to really make sure that everyone is engaged in this effort to provide education, or at least know where to send people that they can get that information. So I think, will there be gaps? Of course there'll be gaps. There are people who, because of their immigration status, are still not going to be eligible for anything. The support that we provide to the safety net and for uncompensated care is going to need to continue, but I think we need to do a best job we possibly can to get as many people enrolled in the right forms of coverage that are going to get them the care they need without exposing them to financial uncertainty. I mean, one of the groups that we've been working with a lot, are the people who do tax preparation assistance or asset development groups, and they talk about this totally in terms of economic stability for families, and so that's the other side of the same coin of the economic stability for providers.
Sure. So another question has arisen in terms of thinking about the need to continue to have that safety net. What information might you have, Judy, about the continued federal support for federally qualified health centers? I know some people have thought with the advent of the Affordable Care Act, the need for federally qualified health centers and sliding fee scales and all will be reduced, but it sounds like that may not be the case. And so a question about, do you foresee the federal government continuing to support those federally qualified health centers across the nation?
Well, yeah, I wish I had a crystal ball, but so I can't say for sure. But certainly everything that we've seen, the recognition in the Affordable Care Act itself of the community health centers as a key place, not only for the uninsured to go, but for the newly insured to go. We've been doing a lot of work with the community health centers on eligibility and enrollment, and I had a chance to go down to Texas and speak to the, hundreds of staffers across the state of Texas that are really going to be engaged in trying to get people enrolled. So I certainly, in my travels and here in D.C., don't hear anybody question the need for continued support and the key role that they will play not only for people who are uninsured but for the newly insured.
Great, great. Well, that wraps up the questions that we have here before us today. I want to thank Judy again for your excellent information and helping us understand how the Affordable Care Act will improve access to care in our nation and in our communities. And again, encourage our listeners here today to visit the Center on Budget and Policy Priorities website at the references you see on the screen before you. If you have remaining questions, it sounds like there's great opportunity to learn more. Thank you all for tuning in today, and we appreciate your attention and your time. And you will receive an evaluation after the webinar. Again, we strongly encourage you to complete the evaluation, not only to give us feedback on this particular session, but also to suggest topics that you are interested in that we could secure for you, particularly in the upcoming year. So thanks again. Everybody have a great rest of your Thursday, and thank you, Judy.
Thank you. Bye, everybody.
Goodbye.